We're going to our next session, which is going to be moderated by our lovely Carla Maul. It's going to be the COVID-19 management around the world session. This ought to be, again, our topic today has been COVID and ECLS. We've had some excellent speakers. Some of the speakers are coming back on, and Carla, who is an expert in this area, is going to be moderating this session. Thank you, Carla, and thank you for our speakers.
Thank you. Our first speaker up is Dr. Sadar Gunadin. He is a cardiac surgeon and a clinical professor at the University of Health Sciences in Ankara, Turkey. His main research interests are patient blood management and prevention of inflammatory response in cardiopulmonary bypass. And his hobbies include half marathons from Asia to Europe. Very impressive. Dr. Gunadin.
Hello, good afternoon, and it's always very nice to be here. The important thing is it's just been, unfortunately, one complete year that Sanibel meeting was the first meeting that I participated virtually last year. It was the first experience. Now it's been one whole year. I've been participated maybe in more than 25, 35 meetings. And now it's the end of the year, the second year, and again, we're together on a virtual platform. So thank you very much for the invitation, and it's my pleasure to be here. So I work here in Ankara City Hospital. It's in the capital city of Turkey. It's a newly built hospital, only 3 years old. And it's really one of the largest hospitals in the area. So I'm going to summarize some of our experiences with the COVID in the last year. So it's a hospital with about 4,000 beds, and in cardiac surgery we have 15 operating rooms and ICU and wards. So before COVID, our caseload for annual caseload was around 4,000, and unfortunately in the COVID era we dropped down to 2,000, nearly half. But the number of ECMOs increased, very close to 200 at the end of the year. So COVID was really a very unexpected experience for us. So in Turkey, we started the report the first COVID patient in mid-March in 2020. After that, in May, we had a kind of lockdown for 2 months. So we dropped down the number of operations. We only accepted the emergency cases and nothing else, because we don't know what we were dealing about at that time. So we had some kind of experience until June, July. We have a kind of relief in the country in mid-July. And unfortunately, in September, it went worse again, and second lockdown. And then a new year, within February, everything was going very well. So we reached to our normal lives. But unfortunately, in the beginning of March, we have a third wave attack by COVID with the new variants and mutants. And now it's terrible. So we'll have a lockdown again, starting this week. So we again really stopped the all elective cases and start doing all emergency cases. So this is the third time we had a lockdown and trying to recover. And when we just look kind of overview in the world, we have 136 million confirmed cases in the last year, about 3 million deaths, and now the vaccination started. And in our country, it's 4 million confirmed cases with about 40,000 people dead. So COVID is a very complex terminology and disease that spending a whole year dealing with only COVID patients, we still don't know what we're dealing with. So how do we understand this? For example, when you look at the clinicaltrials.gov, there are more than 5,000 clinical studies are being held to understand what COVID is. So when you check the PubMed, you see 150,000 papers published in 1 year about COVID. So, and we still don't know what we are going to do. There is something we have learned out of all our experiences in the last year. So about the pathogenesis, so it's ACE2 receptor binding virus. So when it binds, usually it goes on asymptomatic in most of the patients with a very minor infection, just very much flu-like. This lasts for 7 to 10 days. In minority of the patients, like 5 to 10%, we have a real pneumonia, massive inflammatory response, cytokine storm. So if it's moderate, we only use oxygen. If it's severe, mechanical ventilation or ECMO. And sometimes after the cytokine storm, then we have a kind of prothrombotic status. And so there are increased levels of cytokines. So, of course, there's a new type of patient with different hemostasis and inflammatory response. So we try to understand in this whole year. So the coagulation is something different and very, very different mechanisms. So it's a kind of immune response, not a very usual inflammatory response or coagulative response in these patients. So at the end of this inflammatory period, we have a thrombotic period. And when we have a hypoxia, it also induces the transcription factors and also causes a kind of prothrombotic state. So it's a very difficult patient. It's not a DIC patient because prothrombin time or APTT is almost slightly prolonged. Platelet counts are high or normal. So, for example, we always see some kind of patients with a normal platelet count, normal thrombin times, and they bleed. Or sometimes the platelet count is low, and we have a thrombosis in the patient. So this is really still a kind of dilemma that we never have a very good answer. It's a kind of immunothrombosis. It's a different system. It includes immunologic response plus thrombotic response and inflammatory response all. And what do we use to overcome those thrombotic state? So anticoagulant treatment, okay, but none of the studies have proved that this anticoagulation regime is perfect. So there are many different formulas, different recipes, but none of them worked perfectly. So heparin, of course, but sometimes good, sometimes bad. So it's still an ongoing discussion. And in Europe, there are many different studies going on, trying to understand which anticoagulant regime is good for these COVID patients in prophylaxis or in the long-term protection. So at the end of all those different studies, maybe we can have some clear answer to those questions. But anyway, so the 30-day mortality rate is 24%, very high, and postoperative pulmonary complications is 51%, and we are dealing with cardiac surgery. That means we are dealing with very, very high patients. So in the beginning of those pandemic, we have a kind of guideline that to follow in preoperative, intraoperative, and postoperative period. But of course, those were theoretical guidelines and very difficult to follow up. So we tried to put some, let's say 50 or 60% of all those precautions. And sometimes they even didn't work. And we published some kind of guidelines for cardiopulmonary bypass management. My fellow dear friend Alfred Stemmers, we published a kind of review how to deal with this COVID patients. And then when we talk about this review, with what we have said, that we are dealing with the high-risk patients, because if they are male, the risk or the severity of illness goes up to 1.3 times more, smoking 2 times 5 times more, comorbidities 2 or 3 times more or so. So it's a really high-risk patient. And how do we understand with the PCR? Because in the beginning, yes, we were using some kind of PCR. We were discussing the sensitivity of the test. But now, in the last month, it becomes much more complicated because now in clinical practice, we are performing PCR tests and they are sometimes negative. But we understand later that they are mutants, like the English mutant, South African mutant. We even in Turkey detected the American mutant. So the virus change the construction, and so it's sometimes very difficult to detect the virus with the conventional methods in the lab. So it's a really complicated issue. But in the beginning, we were discussing that should we do testing for all patients and all the time? And now, at the end of the year, I can say we need to do the test, but we don't trust the test because sensitivity drops down to 60%, 65% after those genetic mutations. So in the beginning, we designated COVID operating areas. We just made everything separate, far from the central operating rooms. But after 1 year, and now we understand we're going to live with this disease, maybe some years more. So it becomes a kind of routine practice. We are not that much restricted and sometimes liberal to deal with the COVID patients. Because yes, when we have a really COVID positive patient, it's okay. We have a specific OR and everything is separated and even the personnel is different. But usually now the patients change their profile because we have some patients, the tests are negative, maybe they are mutants. Tests are negative, maybe they have COVID before the surgery, and we always have much more difficulty in the early postoperative period with those patients. So our primary focus is to select the patient and to prepare the patient for surgery. We learned a lot of things in this process, of course. We had all the security protection of the personnel and the patient himself, but it's still a kind of problem to protect the other patients around this COVID positive patients. Because I told you, the coagulation system is completely different. The inflammatory reactions are sometimes very much overreacting or underreacting. And we still don't know the pathogenesis, especially for vasoplegic shock. And the conduct of CPB is something different because we are dealing with patients with different D-dimer levels or FTP levels, fibrinogen levels, or so we need to be prepared for those patients. And also in the conduct of CPB, in the beginning, there were many gas exchange discussions. So we are using now large capacity oxygenators for those patients. And we always optimize patients before surgery. I will talk about that later. For myocardial protection, we always use the simplest way. We don't use any complicated regimes for those patients in the myocardial protection phase. So coagulation management does not have any kind of best evidence, but in our practice, we change the initial heparin doses. Of course, ACT is not sufficient enough to follow up the patients, so sometimes we use heparin assay. And also, we try to use Rotan. And so when we have a problem with the heparin, we always think about using DTIs, but I don't have a very good experience with the direct thrombin inhibitors because whenever I chose to use direct thrombin inhibitors, I always had problem with much more bleeding with the patient. So I don't suggest much if you don't have any other chance. So antithrombin activity is very important and anti-10A activity is very important. We never measured that before in our routine clinical practice, but now it's a kind of routine that we always measure everything, heparin assay, AT activity, anti-10A activity, everything. And in the surgery, so we don't have a very clear idea about the fluid balance of the patients. So it's not easy to decide to use ultrafiltration routinely or not. So if we have thinking some type of cytokine storm that we can use ultrafiltration or hemoconcentration. But we have a very good experience with the cytokine filters. So in Turkey, we have different brands of filters with different prices and different quality because in most of the filters do not work in the heart lung machine with those flows, very high flows, let's say. But we always prefer to use cytokine filters in ECMO patients, nearly all, because we believe it works very well. So we change the filters every 6 hours in ECMO patients. So in the heart-lung machines, in the initial phases, we always use cytokine filters, but later we're not very much sure that they are effective in the heart-lung machine in a routine coronary surgery, let's say. So it's not routine to use now in a routine open case, but routine in ECMO patients. So cell salvage has become popular later, especially because we have some kind of blood shortage because of the donation problems. I will again come to this point later. But we're using now cell saver in COVID-positive patients routinely and in complicated ECMO patients, especially in cannulation and decannulation phase. So contamination was a kind of issue in the beginning. So we did a lot of testing in a routine heart-lung machine and routine sets. We checked PCR or anything in the inlet, outlet, everywhere on the circuit, and we didn't detect any kind of contamination. So we studied more than 25, 30 patients, and we think the sets are safe to use. For ECMO patients, we also checked the contamination in any part of the circuit for 35 patients again, up to 7 days, 8 days. And I can say the sets look safe. That doesn't show us any kind of contamination from the virus. So we still organize kind simulation scenarios for the teams to practice oxygenator and circuit change at risk. So we did 2,000 cases this year. We only had two problems to that we need to change the oxygenator and circuit. So it's not very much, let's say, frequent to have that kind of problem. So as a result, heparinization is a bit different now in our practice. So we are using a very tight coagulation monitoring. So blood management, I will talk about later. So equipment looks safe in the heart-lung machines. So ultrafiltration is difficult to decide. You have to evaluate the patients very closely. And myocardial protection should be very brief and safe and simple. So antifibrinolytics. In the beginning, we stopped using any kind of antifibrinolytics because we were not sure, especially for tranexamic acid. But after some time now, in the beginning, we were using it precautiously. And at the end of this year, we are using it again. We are using tranexamic acid routinely in our patient blood management guideline. So now we just return back to normal, and we are using again the antifibrinolytics in our practice. So as my personal experience to manage patients in the heart-lung machine, I can say we should start the treatment of the patient as soon as possible if you find them COVID positive, any kind of antiviral medications or whatever you are using. So we need to postpone the intubation as long as we can, because mechanical ventilation is much more harmful. Very tight anticoagulation protocol, very good preoperative optimization of the patient, and cytokine filtration works very well, especially in ECMO patients. So the most difficult patient profile is test negative but clinically positive patients. So you check for the CT or even at least the lung X-ray of the patient, and you understand this is a COVID positive patient, but tests are negative. So we always think these patients are also COVID positive patients, so we behave like that. So I also want to say something about ECMO. At the beginning, the ECMO results were terrible because the initial results were coming from China, and the survival rate was below 25%. So in the first 3-4 months, we were not thinking ECMO is a very good alternative. But as soon as it's become widespread and even more experienced centers come to play. So this is the current numbers from the ESO. So there are more than 6,000 patients with a rate of 49%. It's very much a good result for me. So ECMO is becoming more and more popular. So we are using much more ECMO. That's why our number of ECMO went up to 40% more this year. So we also published the ECMO guidelines from the Turkish Society of Cardiac Surgery, and we are following those guidelines. So for ECMO, in the beginning, we were very much afraid of using peripheral cannulation. We had a lot of femoral artery problems in the beginning. And later, we have a new technology to use. It's a biflow cannula. I know it's not available in US, but it's available in Europe. In 2019 March, it has a CE mark and was available. So we started using the ECMO cannula. So we are very much happy with that. So we just updated our ECMO protocols, especially for bleeding and thrombosis. So we really worked a lot on that. And so we have a fixed protocol now to deal with specifically for COVID patients, but also we're using this new cannula routinely for every patient. So it's a dual bidirectional flow cannula. So it's 19 French here and 6 French here. So the flow goes in both directions. You don't need to do any additional work around solution like on the side graft or retrograde coagulation, something like that. So we even have a clinical study. We published the first results in the AACS meeting for minimally invasive surgery and in STS meeting for ECMO. So we worked up to 40 patients, and the results were much better than the control group with the retrograde coagulation in ECMO patients. The bidirectional cannula really was significantly better flow in the distal area, peripheric area, and the oxygen saturation was significantly better in that group. So this is the bidirectional cannula in the OR. So you can see both sides flow here. And this is the Doppler ultrasonography. So this is the distal side. You can see that there's a backflow going down. So it's a safe cannula to use. We overcome many much more difficult problems with the especially perfect cannulation of ECMO. And regarding ECMO, my personal experience is bleeding and transfusion are serious drawback. I will also underline the problem of transfusion in ECMO later. So we are using cell saver if we think it's going to bleed, especially in cannulation and decannulation times. We use biflow for peripheral cannulation. And the other problem was that we were facing was the blood shortage, especially after 6 months. So in Turkey, before coming to, so this is the Europe before COVID. So for example, in Germany, there's a balance. So this is the donation, 4.4 million 1 year, and this is the use of ECs, for example, 4.1. So it's a positive balance. So in Turkey, we had a negative balance, but it was okay, acceptable. So 86% of all blood used in the country was coming from the donations. So it was a satisfactory amount in 2018 before COVID. So in 2018, before COVID, in 1 month, there were more than 200,000 donations in the country. But in the COVID era, it dropped down to 40,000 per month. That is 85% lower. So we started having some difficulty in just having some blood, especially in the operations. We even needed to postpone some operations due to the blood problems. So this is before COVID era. In the whole hospital, we were using more than 60,000 blood and blood products. In the whole city, it was 100,000. So in capital city of Turkey, with a population of 5 million people, one hospital was using 60% of whole blood in that city. So we just built up a kind of patient blood management program and implemented it to the whole hospital, and the results were very much satisfactory. We dropped down the use of blood up to 20%. And unfortunately, after COVID era, everything went worse because we just built up the patient blood management program. This is, for example, preoperative anemia treatment. We went up to 400 patients in a month, but after COVID era, everything went down. So patient blood management program is kind of difficult. This is the fibrinogen use, for example, and it dropped down in the times of COVID. So it really affected a lot. But the problem is when we check the results, so our number of operations went half from 4,000 to 2,000, but the number of blood used went up 35% more. For red blood cells, for FFP, it went up to 23%. This were expected. Of course, the apheresis platelet for 468% more. Cryo was going up, okay. Although we just controlled every destruction of the blood and blood units, our numbers were going up. Operations, half, and number of bloods going maybe 1/3 more. Well, we were not sure, so we really tried to understand why. This was very much unexpected data. Of course, we were dealing with emergency operations, complex operations with difficult patients. We don't have a time to preoperative optimization. These COVID patients were bleeding more, okay. So our PBM programs were distracted, okay. So we don't have a very good backup from the blood bank, okay. But numbers are going very, very much high. So we finally understand the reason was ECMO, because the number of ECMO is going up, the number of blood and blood products was going up, although the number of operations were going down. So we just planned to solve this problem, and we just updated our ECMO programs, patient blood management programs in ECMO, and tried to solve this problem. So finally, at the end of this year, now we understand that it's still an ongoing problem, especially for us, because we have the third lockdown now. And we are going to live with this disease and with these patients. We don't know how long, maybe 1 or 2 years more. So it becomes a kind of routine. And we are, of course, when we know it's a very positive patients, solutions is much more easier. But usually we have patients either now the test is negative, but they had COVID before. So they always have a problem in the early positive area. And sometimes we have patients, we don't understand why they are bleeding or why they're thrombotic. So it becomes a kind of the gatherings of the experience, and we try to deal with those patients now. But of course, we are always updating our information, because the advice given at the beginning of journey should be updated as we learn more, and we are learning every day still at the end of this year. So especially for ECMO, I need to do something, because before COVID, of course, we were using much more blood in ECMO patients, but now it's out of control in our hospital. So we are trying to limit the use of blood and blood products in ECMO. And we try to understand the pathophysiology of the COVID patients, coagulation, inflammation. We have an idea, but still we don't know, because we don't have evidence. It's only been 1 year. We have 120,000 papers, but not evidence, unfortunately. So teamwork becomes much more important now. So we need to come together, discuss, because everybody has an idea. It doesn't mean how experienced physician you are. It's only 1 year experience, so everybody can have the same level of experience to discuss. And especially the blood will be really an important problem in the near future for COVID patients and for the hospitals. So we need to take the precautions as early as possible for those patients. So we need to update the patient blood management programs as well. Thank you very much. So this is a huge hospital. I'm driving the golf car, the buggy car around the hospital with my sword from the Star Wars to protect my patients. Thank you very much.
That's awesome. Thank you, Dr. Gunadin. Are you able to stay with us for about another 40 minutes so we can do a panel discussion? Yes, thank you very much. Our next speaker really doesn't need an introduction today. Dr. Akram Zoho, who is the medical director of ECMO at Washington Hospital Center, and someone who I've had the privilege of working with for the past few years. Dr. Akram.
You're on mute. You're muted right now, sir. Yeah.
Okay, can you see my screen?
Yes.
Excellent. Thank you, Carla, and you know, it's a great honor to be here. So this topic is related to the first presentation I've given today, but this with main focus on the COVID ECMO. It's very interesting to hear about the interaction between inflammation and coagulation in those patient population, which very challenging sometimes to deal with. Okay, so this is the coronavirus, essentially. And as you can see, the coronavirus, it has very specific characteristics, one of which it's a cytopathic virus, which induces very intense inflammation by infecting the cells and entering the cells through the ACE receptors. And as you can see on the diagram here on your right-hand side, once the virus enters the alveoli, it induces inflammation by attacking the alveolar macrophages that get activated and release cytokines, mainly interleukin-6 and CSF, that will induce further inflammatory interaction, recruiting more inflammatory cells and monocytes, and goes from that cellular immune response to the right panel side, where you can see there is also a component of the humoral immunity with the stimulation of the B cells, triggering inflammatory response. And this inflammatory response in some patients, unfortunately, goes beyond control and can induce further damage to the healthy tissues and the alveoli. And as you can see here, in those patients that have intense hyperinflammatory response, they progress into ARDS, sepsis, and multi-organ failure eventually. Now, I would say something about the inflammation just before I move on. The inflammation is a dynamic process. So when you capture a patient in a certain stage of the inflammation, it might be different based on the time, but also might be different based on the bodies of the patient and how they react in general to the inflammation and to the infection. Meaning sometimes using some sort of unified treatment for all patients will not work. And I'm going to show you some examples shortly, because just we try to interfere on the process in different times or, in the wrong time. So back to this concept of inducing alveolar inflammation. And as the disease progresses, and as you all see in this editorial by Dan Brody, that the lung compliances and the consolidation infiltrate of the lung evolve over time. And this is just the natural process to respond to the inflammation. With inflammation, it always comes activation of the coagulation system and the coagulation cascade. And the way is by damaging the healthy endothelial and epithelial cells and the release of the thrombin factor, tissue factor, that will trigger the coagulation cascade and trigger the platelet aggregation and clot formation. Now, the patient can go that way where we become like prothrombotic in nature, but some subset of patients that can progress into uncontrolled bleeding and DIC. And it's very difficult to predict in which way the patient will go. But in general, in COVID, we've seen more thrombotic events in comparison to the bleeding. Here, in this retrospective analysis, showed how the D-dimer and the elevation of escalation of the D-dimer as in being inflammatory mediator associated with poor outcome and non-survival. And in this histopathology look at the lung tissues, you will see the COVID-19 induces the degree of tracheobronchitis and then diffuse alveolar damage and vascular thrombosis, as you can see on this on the right-hand side. So to prevent the thrombotic events, there are multiple guidelines. I'm just using chest guidelines as an example, where they're using, where the recommended prophylaxis, Dvt prophylaxis, essentially for patients who are non-critically ill, hospitalized, or critically ill and hospitalized, and they recommended using low molecular weight heparin just to reduce the incidence of staph exposure. And once the patient, if the patient have venous thromboembolism, the recommendation is to use parenteral anticoagulation with low molecular weight or unfractionated heparin. So it was a well-recognized problem by the societies, and that's why the recommendation comes about treatment of the thrombosis. I'm going to touch base just on some of the drugs that we use as immunomodulator. So this is the recovery trial, and it was controlled open-label trial that assigned patient to dexamethasone versus usual care. And the dexamethasone dose was 6 milligrams once a day for up to 10 days. And the dexamethasone group has lower mortality, improved survival in comparison with the usual care. So that's why dexamethasone become part of our routine care for COVID-19 hospitalized patients. And this is the Solidarity trial, and the Solidarity trial looks as the remdesivir versus control, and there was no benefit associated with that drug use, either with it or hydroxychloroquine or some of other immunomodulator. What about the IL-6 inhibitors? So the IL-6 inhibitors showed it actually has some beneficial effect, showed improved survival and 90 days when we use those patients, especially also if the patient have a degree of progressive hypoxia or an increased oxygen requirement. Okay, so we'll talk specifically about ECMO. So this is one of the first studies that came out, positive studies that came out regarding the COVID-19 ECMO outcome. 12 patients, 8 of them were survived due to hospital discharge. And in the study protocol, they used anti-TNA level of 0.2 to 0.3. But also they recorded thrombotic events that up to 11, which is 11 from 12 patients was 92%. So it was early on recognized issue in the ECMO patients. So this is, of course, the Paris study, Paris experience was retrospective analysis. The survival to the hospital discharge, the mortality for the ECMO was almost like 37%. But in their anticoagulation group, they increased the target for anticoagulation to use a PTT of 60 to 75 or anti-TNA 0.3 to 0.5. And that's the same center where they conducted the Eolia trial, where they used PTT 40 to 55 or anti-TNA 0.2 to 0.3. So definitely they drove their anticoagulation regimen up. And these are the rates of the complication that they recorded in those 80 plus patients. And as you can see, there was high incidence also of bleeding in this cohort. It's massive hemorrhage, like 42%. And the requirement for blood transfusion was also 77%. And when you look at the ECMO-related complications, 27% of the population of the study cohort they require changing the circuit more than once. This is the study Asif Mustafa from Rush University when they commented on the Protic Do, and they had an excellent outcome. But for them, they used direct thrombin inhibitor with a PTT goal 45 to 70. And after patient get weaned off ECMO, they continued with anticoagulation with warfarin with INR goal 2.5 to 3.5, or using Eliquis on those patients. And of course, this is the report from the ELSO about the outcome for the ECMO, which was very encouraging results to see. And also we know that actually, in this multicentric cohort study shows actually there is better outcome for ECMO group in comparison to non-ECMO group. So I'm trying to emphasize that the point that Dan Brody made early on today about the potentially beneficial effect of ECMO. And the effect of ECMO survival can last up to several months, 6 months after the being put on ECMO. These are the most updated guidelines for ECMO COVID-19, and I'm showing this to emphasize about the fact there is a cytokine removal was mentioning to be considered in management of those patients. Now, we don't know much about the cytokine removal and how beneficial it is, so I'm looking forward to upcoming talks and presentations during our conference about the cytokine experiences from other centers. But this is just a report came from Paris Center, Labiti, Matteo Schmedet, and they had 22 COVID-19 patients, 11 of them would use the cytosorb. And what they noticed that the cytosorb led to reduction in the IL-10 and IL-6 on those patients. Now, we don't know how that will translate in reality to actual patient outcome or how that will affect the management of those patients. What I'm going to show you just this paper we submitted, but it's from our own local, it's from our institution. And essentially 27 patients, 10 of them were alive to discharge and 11 of them died. And they were comparable group when it comes to age, body mass index, the pre-existing conditions, and even to the use of other immunomodulators on those patients. And the good thing, majority of those patients, they were prone, they were properly managed by either inhaled ibuprostanol, neuromuscular blockade. As you can see, we used the three major anticoagulants, the systemic heparin, the argatroban, and the bivalirudin, and in those patients. When we looked at the complications, so definitely the complications were extremely high or high in the patient who died. And we had a higher incidence of, we had a higher incidence of need for blood transfusion, renal failure that require renal replacement therapy, and secondary infection, mainly in the non-survival group. And these are the markers of inflammation and coagulation. And I'll get your attention to LDH was significantly higher in the patient who died. And also when it comes to the TAG and thromboelastogram, the MAs were also lower in the patient who died. And then the G value also was lower in the patient who died. So then we did a correlation between both the inflammatory mediators and the coagulation factor. And this is the ECMO survival, and this is the ECMO non-survival. So there was definitely very strong correlation between the inflammatory mediators and the coagulation abnormalities on those patients. And majority of those patients, just I failed to mention, majority of patients who died, they died from multi-organ failure. So to summarize, this is previous work actually we've done, but it's not related to COVID or ECMO. But essentially, we were able to use the some sort of mathematical modeling and looking at the inflammatory mediators evolution over time to see in which stage of inflammation the patient will be on, and if there is any benefit to have some sort of personalized approach to target certain subgroup of patients. And I think that might be one of the solutions, since we're dealing with such a challenging disease, is to study the inflammatory reaction of these patients and have some sort of tailored, personalized, or some sort of like precision medicine approach for those patient population. And with that, I can take any questions.
Do you mind if we hold the questions until after our next lecture until we can do a panel discussion?
Sure.
Perfect. Thank you very much. Our next speaker is Dr. Filip de Sommer. He is a certified perfusionist in Belgium, where he is the director of perfusion services at the University Hospital of Ghent. He has his doctorate in medical sciences and has published over 70 peer-reviewed articles. So thank you very much for joining us. It's all yours, Dr. Sommer.
You're still muted, Doctor.
Yes, sorry, I'm going to try to share my screen. Can you see this? First of all, I would like to thank Sanibel for the kind invitation. I really envy you when I see the beautiful background with the sun, because I can tell you in Belgium, it's for the moment freezing cold. So enjoy it, I would say. I was asked to talk a little bit about COVID-19 in Belgium. And for those who are not acquainted with Belgium, Belgium is a relatively small country. I also want to mention that I have no disclosures to make with respect to this presentation. We have a population of about 11.5 million people, and we have the typical European Caucasian population with a relatively high life expectancy. As you can see, it's about 79 years for males and 84 years for females. So we have a relatively old population also. And we were struck, as you all were, by COVID last year. So if you look to the results in Belgium, then you see that we had till now, because these data are up to date till yesterday, about 900 cases which were detected. We have a rather high death count of 23,000 patients till now. And we had 66,000 hospital admissions of the whole of Belgium. As you also can see in the graphs, in the initially here, you do not see a lot, but the reason was that in Belgium at that time, the testing capacity was rather low. It was built up, and the second wave, as you can see here, we had much more cases, but this was due because of a much higher testing capacity in the country. For the deaths, you can see we had in the first wave a relatively high number, but also in the second wave, we were struck quite high. If you look to the number of tests, like I was just explaining, we are testing now more than 11 million tests have been performed. And as you can see, over the last 7 days and 14 days, we seem to have a slight decrease in the number of positive tests. But nevertheless, we still have about 9% of our population which is tested positive. And the vaccination started up. For the moment, about 1.9 million vaccines have been given, and this is more or less 20% of the adult population. If you look to the healthcare group of people, then we have about 95% of all healthcare workers in Belgium who now have antibodies because they were considered as a target group together with the older population in order to maintain our hospitals working, because in the beginning we had also a lot of personnel which actually was affected by COVID. If you compare this number with the average population, then you can see that the antibodies are present for more or less in 16% of the non-vaccinated population. So then more particular to the hospital admission, the capacity in Belgium on intensive care beds is about 2,000. That's important to keep in mind. And as you can see here, we had about 5,000 patients coming in the first wave. It was even higher in the second wave. But as you can see, we were always in a very bad situation on our intensive care, as in the second wave, about 75% of all potential beds were taken by COVID patients. And this had, as was also mentioned by Dr. Gunaydin, a huge impact on the regular surgery and treatments in the hospital. Today, this is slightly better because we have adapted over time. But nevertheless, you can see even today, we are again at around 900 of the 2,000 beds taken by COVID-19 patients. Also interesting to notice is that when we had the first wave and this was going down, we actually kept it at a very low level. Then we had the second wave, but we were never able to bring it back to the same level. And now it's actually a competition between vaccinating people and trying to get them out of the hospital. So we hope we will win the battle by increasing the speed of vaccines. But in Belgium, as in many European Union countries, we do have a problem in getting enough vaccines in Europe. And the number of patients who has been on a ventilator, as you can see in intensive care, it's about 80% of the patients who are residing there. Now, if we compare that with the ECMO capacity, this is the number of ECMOs performed in Belgium, then you can see in the second wave, we had 90 ECMOs running, which is a very high number if you take in consideration the number of intensive care beds and also the population number in Belgium. So if I go to my own hospital, in the beginning, we were relatively reluctant to put patients on ECMO because there was the initial experience in China who was stating that it was probably not worthwhile to do. So in the first wave, we had about 7 patients who went on ECMO, which were very selective. And as a result, probably of that, we had excellent results because we had a survival rate of about 85%. If we went in the second wave, we had much more patients. It was about 20 patients. And as you can see now, we have the same results as was actually published by ELSO and many other authors of about 52% survival. What also is remarkable is the duration of ECMO increased over time. It was about 12 days in the first wave. It went already up to 20 days in the second wave. And as you can see in the third wave, which is still ongoing, we have about 25 days. And this is also what we see in the hospital. Patient seems to be sicker. And in the last wave, the ongoing wave, we also see that patients are younger because the older population in Belgium is now 100% vaccinated. So it means that because of that, we can avoid them to get them in the hospital. Now, when the patients were actually transferred in the beginning, we were really concerned because of the fact that there was a lot of thrombosis noticed, especially also in China. And we didn't know how we are going to adapt that in our ECMO program. Now, if you look, of course, to the prothrombotic profile, we have to wonder what part is specifically related to COVID and what part is just related to the fact that you have a very sick patient with a severe lung disease, which also by itself will indicate a thrombotic response. So the first thing we noticed then after the Italian experience, because Italy, as you know, was struck first in Europe, we noticed that in China, in many of those high numbers of thrombotic patients, actually those centers did not use anticoagulation prophylaxis in their critical ill patients as a standard. In opposition to Europe, where I think this is a standard policy that every critical ill patient would get prophylaxis. Nevertheless, if you look to 3 large studies which have been performed with prophylaxis against no prophylaxis, then you can see that you have a tremendous reduction of the risk profile of the patient, but nevertheless, you do not completely control it. And we do know from several studies that if we look to ECMO patients, non-COVID ECMO patients, that if those patients do not survive and we do autopsy, that there are much more thrombosis found in those patients than were clinically present. And that means that if you prolong the duration of ECMO, that the number of thrombosis which has been found by autopsy is also increasing. So this is a consideration we also had to take into consideration. So the question was then, are we going to augment, as was shown by the previous speaker, the number of anticoagulation? Are we going to give higher doses of unfractionated heparin with the risk of more bleeding? Or are we going to stay with our classical anticoagulation program and see what it brought to us? And that was a point of discussion at the time. One of our major concerns in that respect was how we were going to measure then in an accurate way the unfractionated heparin, because we can measure anti-10A, but it's time consuming in our hospital. It's not something you get very fast. And then the question is this superior? Yes, it is superior if you measure it in plasma, but is it also superior if you use it in clinical patients? That's a little bit more of a debate, but what is for sure that it's probably a lot better than APTT or ACT measurements, which have a poor correlation in general with the heparin level. So a second point was then, these are all inflamed patients. We do know that inflammation has an impact on the antithrombin 3, which is necessary for a good anticoagulation for unfractionated heparin. So this was another point of consideration. Are we going to change our protocols with respect to the amount of antithrombin measured? And then finally, we were concerned about the potential for a higher number of oxygenated thrombosis, which, by the way, we have noticed. It's certainly in the same neighborhood as was shown by the previous speaker. It's about 27–30%, I believe, where we had to exchange oxygenators. And then the question is, how can we detect in the best possible way a beginning oxygenated thrombosis? Normally in our institution, we used, besides some other measures, D-dimers in order to detect this. But we do know that this is not working very well in COVID-19 patients. Because first of all, most of them do have already very high D-dimer levels to start with. We have had patients coming in before ECMO with more than 20,000 D-dimers measured, which then remain high, and there is rarely a good correlation with oxygenated thrombosis, mainly because probably the D-dimers are also formed into the lung, and this is probably biasing then our results. In consideration with that, of course, we also noticed that they had a severe inflammation, which means that there were a lot tissue factor bearing cells, which are again capable in instituting very fast a prothrombotic reaction in the body. So beside that, we normally also use the measurement of pressure drop over the oxygenator, which we still maintained, and that seemed to be as predictive as it was before, meaning it gives you an indication, but of course it's also not 100%. And here you can see some of the results of the first wave. This was a patient, for example, where we had to exchange the oxygenator. The yellow one here, it's a different type of oxygenator, so it's not uncommon that it started high. It's just because of a higher resistance over the oxygenator. Then the monitoring, we normally measure in every ECMO patient in our institution on a daily basis antithrombin 3, ACT. We expanded that for the COVID patient with viscoelastic testing. Hemolysis was already measured every day, and the inflammatory parameters beside IL-6 was also CRP and eventually carboxyhemoglobin. For the viscoelastic testing, we believe that this was very helpful. You can see here some examples where we have here a patient which is, according to our standards, over anticoagulated, where this patient is clearly a patient who is under anticoagulated. And if you would see that with the values, then you can see here, this is on the low molecular weight heparin, that there is a nice correlation with the concentration measured in that patient. This is another example of some of the patients. The patients here we would consider in a safe situation. And as you can see here, there is a more protomotic signature where we would enhance the anticoagulation in that patient. We were also concerned with the platelets because we do know, as was also mentioned by the previous speakers, that some patients had very high platelets, other patients had normal platelet counts, and others came in with relatively low platelet counts. But what we do know is that when we give unfractionated heparin, that we will further activate those platelets. And then the question is how far or how much might this influence the bleeding and thrombosis in those patients. We also know that once you have them activated, they are a source for a rapid production of thrombin in the patient. And that's, of course, something, especially in those patients, we want to avoid, because we can already assume that maybe in some cases antithrombin 3 levels might be already very low. So the discussion was then, are we going to use unfractionated heparin, or are we expand more on the low molecular weight, as we do know that low molecular weight heparin is activating less platelets than unfractionated. As you can see here, there's a clear activation. If you just look to the platelet factor 4, then you can see 69% can actually be taken by unfractionated heparin. These are, again, from the first wave, some of the platelet counts during the ECMO. And as you can see, there were high differences. Some patients remained very high, others remained in more normal levels, but it was very difficult to predict what type of patient you are going to get. In order to avoid this platelet activation or better control it, we actually use a system which has been first published in Germany, where we actually use acetylsalicyl acid in combination with heparin. And as you can see here, this was a patient where there was already some platelet strings in the oxygenator, and by adding the acetylsalicyl, we were able to control it and to maintain a longer lifespan for that oxygenator. As you can see here, this was after starting up the acetylsalicyl. There is a reason for that. The reason is that when you actually give a patient heparin, then you will have an activation. If you actually give that after aspirin just in a control, then of course there will be less aggregation because of the aspirin effect. But if you combine it, you can see you have an improvement of the activation of the platelets. So in all our COVID patients, we have given acetylsalicylic acid as a standard, with exception if we would see mucosal bleeding, then it was stopped for the duration when we saw or observed this bleeding. Once it was under control, it was restarted. The antithrombin 3 was another aspect we wanted to control quite closely. And as you can see here, when you do that, you can actually, again, prolong lifespan of an oxygenator. This is before antithrombin 3. This is after antithrombin 3 substitution. And as you can see, by substituting it, we were able to maintain it well within the reference levels used in our hospital. But many of those patients needed on a regular basis antithrombin 3 substitution. And finally, we were a little bit afraid of the amounts of hemolysis because those patients need really high flows. We agree with Le Breton in Paris that most of the patients have easily flows 4, 5, 6, and we even had patients on 7 liters of ECMO flow in order to maintain good oxygenation. And then you can question, might there be an impact on the hemolysis levels observed during those ECMO procedures? These are the free plasma hemoglobin levels in those patients. This is in milligram%, and as you can see, we rarely have values above 20 milligram%. So it was possible to maintain these high flows without an extremely high hemolysis level in the patient. However, it doesn't mean because you have a low plasma hemoglobin that there is no harm or no potential harm for the patient, because this is the evolution of haptoglobin concentration. And as you know, haptoglobin is an inhibitor of free plasma hemoglobin. And this means that it was exhausted more or less after 6 days. So meaning that even we don't measure a high number of free plasma hemoglobin, there still was some silent hemolysis present. And this, of course, has a negative effect. We do know it has a negative effect on platelet aggregation, and it will have a negative effect also on the endothelium and also the endothelium in the lung. Inflammation, it was already mentioned. Most of our patients started with a very high fibrinogen, and when they were weaned, there was almost, in most of the times, a normalization of the fibrinogen. In inflammation, we found a relationship between carboxyhemoglobin, which is actually a parameter which reflects more or less the diffusion capacity in the lung. And we saw that there was a nice correlation with high levels of CRP. So apparently, when there was an increase, so we had no good control over the inflammation, then we saw that also the diffusion became worse. If we could control it by changing, for example, antibiotics, we saw also that diffusion improved in most of the patients. So to conclude, we have certainly seen in Belgium distinct differences between waves, and every wave, the patient seems to be sicker than the wave before. This was reflected by longer ECMO durations for those who went on ECMO, and we also saw much more SIR-infection in those patients, probably also due to some of the newer therapies which were used, which were blockers of IL-6. There were, of course, the corticoids, which were already mentioned. We also used convalescent plasma in some patients. This might have had some impact, but it's unclear at the moment. We certainly noticed that COVID-19 poses a potential higher risk during ECMO. It's more challenging, also because the duration of ECMO is higher. But apparently, to the latest European results, if you normalize the problems seen by the duration of the ECMO, it seems to be very comparable to those of a pneumonia ECMO patient. The monitoring of the hemostasis should certainly not rely on one parameter, and we should try to address individual patient problems as close as possible. Nevertheless, we are still learning, because in a recent publication, and I remember there were even 2 publications, show that if you use, for example, CytoSorb in COVID-19 patients, they have a much higher mortality. So the latest European recommendation now is not to use CytoSorb in COVID-19 patients, and especially not in the first days of the ECMO procedure, as apparently this increases mortality. Thank you very much for your attention.
Thank you very much. Very informative session today. So if we can we go, and we're going to take about the next 10 minutes for us to have questions and answers in our panel discussion. Questions from our panel?
What was the aspirin dosing? I'm sorry, go ahead, Susan.
You're probably going to ask the same question I was. Anyway, there's a lot of questions from our participants that's talking about the regimen with aspirin and dosage with the heparin. Can you give your dosage on that or talk a little bit more about that?
Sure. Normally, when they have extremely high platelet counts, for example, 400,000, we give 100 milligram twice a day. Initially, we did it in one dose, but we have seen that apparently this is less effective, and there is some literature supporting this in patients with acute myocardial infarction, that it's better to spread it in 2 doses on 24 hours. If they have low platelet counts, then we lower the dose down to 50 milligrams.
Would you use that with DTIs as well as heparin?
Yes, we had some patients which were on bivalirudin. We had good results with that. We didn't notice more bleeding. We also didn't notice that we had more circuit changes with bivalirudin. But of course, it's a more expensive drug. The nice part, though, is that we had much better control in those, because that was in patients who developed HIT. We saw a very rapid increase again of platelets. So that was the benefit of it.
So, Filip, how do you follow up which tests do you use when you are using bivalirudin?
We use APTT. And we use more or less the same values as Dr. Akram was mentioning, about between 45 and 70.
Okay.
Have you ever, again, I asked this question earlier in another discussion, have you ever thought about using Aggrastat and just continuous use of your heparin product?
We thought about that.
I mean, the results are outstanding. I just wonder why people use this.
We have thought about it, but we haven't done it for the moment, because the problem is a little bit that we were confronted with so much new information with those COVID patients that we wanted first to see what we could do according to our normal procedures and where we could adapt them. But it's certainly a point we are interested in to look to dig in the future. I would like to ask a question to the panel. There has been recent research in Europe showing that in COVID-19 patients, that those patients who develop most easily thrombosis, that there apparently is a shutdown of the fibrinolysis system. So you have a very high D-dimer content in those patients, but apparently fibrinolysis is shut down. Is the same observation made in your centers?
It's this Akram, thank you very much. I mean, this is a great point. You know, for me observing, but this is, you know, in my limited center experience, observing the tag, it's reflective of shutting down of the fibrinolysis for sure on those patients. And it was, you know, it was very, very interesting observation. And, you know, I'm trying to understand what should we do about it. I mean, you know, but it's very interesting. Yes, I did.
And would you dare trying to give them very low doses of fibrinolytics? Because that was one of the pathways in Europe which are discussed right now, if we should do that, yes or no. But of course, it's not something you want to do without a good reflection first.
Right, exactly. But that's the thing. If it is, you know, if it is just abnormality in the tag, I am not sure if we address that with antifibrinolytics. Of course, the picture will change if there is evidence of bleeding, you know, clinical bleeding on the patient.
I don't mean antifibrinolytics, I mean fibrinolytics.
Oh, fibrinolytics.
Because it's a shutdown of your fibrinolysis system, which is probably causing some of the thrombosis issues seen in those patients.
No.
And there are some European groups now who are reflecting on giving very low doses of fibrinolytics in order to counteract the shutdown.
No, I didn't think about it. That's very interesting.
I've got a question. uh, Dr. Summer, Dr. Sar, what do you see as far as what do y'all feel is the initial cause of the huge escalation and the shutdown from COVID over in your area? I mean, what do you see as, is it because of the variation, or is it because of testing, or is it because of not enough drug, or what's going on over there?
For Belgium, I think it's easy to explain. We are a very dense populated country, so you should see it as New York. We have more or less the same number of inhabitants. It's of course a little bit bigger than New York, but not so much bigger. But the fact that we have a lot of contact potential between people living very closely together, it's certainly one of the factors. Then what we have seen in especially the second wave and the third wave are the genetic mutants. So in the last wave, the wave we are having at this right moment, we see there is a higher incidence of the UK variant, which seems to be more contagious. It's not making people sicker, because initially we thought it was also making people sicker, but that's apparently not true. But it's much more contagious. So you have it faster when you have had the contact. And the last point is we also have the South African version, and that one is a really nasty one. Because we have the impression that even the vaccines are not always very effective against that form.
For us, especially in the third wave, like Filip said, we are really having problems with the mutants, especially the South African mutants. So, for example, in the Black Sea region of Turkey, it really just went just rocketing in 2 weeks, and now they're showing the map like in different colors, like red becoming the most dangerous one. So now all Black Sea region is completely red because of the South African mutant. And so the reason was maybe financial for Turkey, because until, let's say, February, everything was going perfect. And then the government says it's okay now, so we can have a kind of loosening for the precautions. And as soon as we have some liberty, then everything went bad. And plus the mutants, now it's terrible.
And I think probably what also plays in Europe is the fact that although we have a lot of factories making vaccines, that the supply of vaccines is still relatively low. If I compare it, for example, to the US, if I'm not wrong, the US population has now been vaccinated for about 40%. If you compare that, Belgium has for the moment 20%, which is more or less the average, I think, for the European Union. But if you compare that to Israel, who already has, I think, 60%, to the UK, who already has 50%, then there is a problem also with the supply, because we can vaccine whatever person if we have the vaccine. So the centers are there, it's very well organized, but we don't have sufficient vaccines to do it faster.
Dr. LaRusso from the Netherlands seemed to think it was kind of an attitude in certain cultures too, which we have in the US, about actually accepting the vaccination as a way to conquer this.
That's also true. But it's especially, Roberto is working in the Netherlands, as you know, and the Netherlands has a certain region in the country, they call it the Bible Belt, where you have very Orthodox religious people, and they have a concern with vaccines in general, not the one for COVID in particular, but with vaccines in general. And that makes it very difficult because they are very suspicious. They believe that you should never vaccinate someone because they believe that because of their religion, that will help them in the first place. And that's very difficult to reach those people because once you're convinced about something, then it's very difficult to break it through. And especially when you have a situation like now where they see a lot of people are getting sick, But nevertheless, there are still the anti-vax movement. I think they also exist in the US, also exist in Europe. And if you see the fake news which some of them are spreading, that's really upsetting. But okay,
if I can make one comment, I was just going to ask you about the small minority of clot formations in certain vaccinations that the media is hyping, at least here in the country. I know AstraZeneca, now Johnson & Johnson. Can you make any comment on that before we move on?
In Europe, it has been a concern. Although it's a little bit strange, because if you look to, for example, the Johnson & Johnson, there's actually the same type of vaccine as AstraZeneca. So it's actually a weakened flu vaccine, which they use as a carrier for the vaccine, in opposition to Pfizer and Moderna, which are actually a complete new type of vaccination. But nevertheless, if you look to the numbers, I think for Johnson & Johnson, it were 6 cases on 7 million vaccinations. That means that's less than 1 on a million, which is probably quite comparable with a lot of other vaccines. But nevertheless, because it's in the media, there is a concern, and there are people who are actually refusing AstraZeneca in Europe. The problem is that due to the shortage of vaccines, that most governments are very reluctant to say, well, we are not going, or we are going to give you a specific vaccine. You have to take what you get. And that's also giving some opposition, of course.
Well, I'd like to thank every one of you, and thank you, Carla, and thank you all for all your great expertise on this subject. We look forward to having you as speakers in the future. So thank you again for everybody's presentation, and we love your answers.